This short film depicts a study, the effect of an osteopathic treatment of D6 to D12 plus ribs on the peak flow and posture, supervised by their promoter Yves Warinier. 3 students, Bas Nering, Mats Daams and Leonard van Hoof of the International Academy of Osteopathy in Ghent, performed the research in order to get their bachelor degree at the University of Wales. Study design. This study is an experimental study with a cohort of 42 subjects. It was designed to determine the efficacy of something previously untried. In this case, does this particular combination of mobilizations and muscle energy techniques, or METs, influence one's posture and peak flow? Hence, every subject was treated with 2 different treatments. The first treatment was a sham treatment, consisting of several backstrokes and thoracic and lumbar massage. The second treatment was a treatment of interest in this study. Joint mobilization is a manual therapy intervention, a type of passive movement of a skeletal joint. Usually, joint mobilization is aimed at a target synovial joint with the aim of achieving a therapeutic effect. When applied to the spine, it is known as spinal mobilization. The purpose and efficiency of osteopathic mobilizations and manipulations is to regain maximum and pain-free movement of the musculoskeletal system. Yet several hypotheses explain the biomechanical, neurological and psychological effects of osteopathic mobilizations and manipulations. Multiple studies provided evidence that even a single session of mobilization can lead to a measurable reduction of pain at rest and also greatly nullify the pain experienced while performing the most restrained and painful movement. Muscle energy techniques describes a broad class of manual therapy techniques directed at improving musculoskeletal function, joint function, and improving pain. Muscle energy techniques are used to treat somatic dysfunction, especially decreased range of motion, muscular hypertonicity, and pain. Objective. The impact of osteopathic intervention on posture and peak flow is not firmly established in scientific literature. That is, when osteopathic treatment consists of mobilizations and METs. An osteopath beholds the human body as a singular, complex, and mechanical unity. Therefore, the solemn use of osteopathic non-manipulative techniques on these isolated sections of the body wasn't expected to hold significant results. This being said, the objective of this study was improving mean peak flow and overall posture by using METs and mobilizations. Methods. The spirometry is firmly established as the most commonly used of the pulmonary function tests. It measures lungs function, specifically the volume and/or flow of air that can be in and exhaled. In this study, the data considering peak expiratory flow had the main interest. Using the diaphoremetric 4D scanner, 6 different measurements were acquired: trunk torsion, trunk length, trunk imbalance, kyphotic apex, lordotic apex, flèche lombaire. Practical execution. Each participant entered the lab on their own. All of them got the same introductional talk and were given the same amount of time to read the informed consent and pose the questions that afflicted them. Each subject was individually measured and weighed. One at a time, each subject was positioned in front of the diaphoremetric 4D scanner. One of the researchers took the necessary measurements and sent the subject to the next measuring station, the Spirometer 2 Smart. The researcher operating this device explained the procedure and motivated the participant throughout the 3 peak expiratory flow maneuvers. After these initial measurements, the first sham treatment was conducted. Following this first treatment, both the diaphoremetric 4D scanner and Spirometer 2 Smart were used to get the wanted second set of measurements. The second treatment, containing mobilizations and muscle energy techniques of vertebrae D6 to D12 and rib 6 to 12, was executed before the last set of data was collected. At the end of the experimental study, the participant was thanked by the entire research team and was accompanied to the door. Premise. Articular mobility is easy to link with posture. For example, when sternochondral articular mobility is diminished, due to scar tissue, etc., the position of the ribs and thus the linked vertebrals is influenced by this loss of mobility. This being said, when one's articular mobility is improved, you should expect their posture to improve equally. Diaphragm. The human diaphragm is anatomically linked with D6 to D12 and its correlating ribs. Thus, when the mobility of these bony structures and the quality of the soft tissue layers in these regions is positively influenced, one can argue that the functionality of the diaphragm should increase. Results. None of the results were significant. Posture wasn't impacted with changes in trunk torsion, trunk length, trunk imbalance, kyphotic apex, lordotic apex, and flèche lombaire, all lacking in statistical relevance. Even peak expiratory flow did not change remarkably. The required 0.05 wasn't even near obtained. In these tables, you see how the calculated means did not back our envisioned results. As portrayed in the previous two slides, these calculated means of lordotic apex, flèche lombaire, and peak expiratory flow did not unveil a significant change. Discussion. Treatment was inflicted on D6 to D12 and correlating ribs. As said prior to the study, this was not expected to significantly influence human posture and peak expiratory flow. Human posture is dependent on one's feet, knees, hips, pelvis, not to mention the pelvic floor, lumbar, thoracic and cervical spine, weight, muscle tone, etc. When D6 to D12 is treated on its own, no noticeable change occurs. The process of measuring PEF is quite exhausting. With performing 9 measurements in a time period of 30 minutes, some of our subjects were clearly out of breath and not properly conditioned to withstand these conditions and still deliver the envisioned results. Whilst executing the peak expiratory flow measurements, subjects didn't perform each cycle with the same determination and enthusiasm. Therefore, some had high results on the first measurements. Others acquired their highest peak in the second set of measurements, and the third group performed remarkably better the third time around. Quite noticeably, too, was a sheer difference in intensity of blowing into the spirometer 2 smart. Any subject could differ more than 3 or even 4 liters per second in peak expiratory flow due to lack of determination and effort. Conclusion. To conclude, the combination of administered mobilizations and METs doesn't significantly influence posture, nor does it affect peak flow. The study was not able to link these particular mobilizations and METs with an improvement of posture or peak expiratory flow. Of interest as next research topic would be, what is the influence of a generalized osteopathic treatment consisting of manipulations, mobilizations and METs of the spine starting at C0 till L5 on posture and peak flow?